Harvey and Nanya for a great job moderating the last session, and it's our pleasure to be here this morning. Myself, I'm Samal Desai. I'm a board-certified dermatologist in private and academic practice in Dallas, Texas, and it's my pleasure to co-chair and moderate with my friend and colleague, Professor Marwa Abdallah. And we will be moderating the next 40 minutes of this block. And it's our pleasure to have our first speaker this morning, my friend and colleague, Dr. Davinder Parsad, who needs no introduction, but he gets a very good introduction anyway, because he's helped do such hard work behind the scenes to put together this year's Vitiligo International Symposium. So congratulations to him and Dr. Hamzavi and the whole team. As all of you probably know, Davinder is professor in the Department of Dermatology at the Postgraduate Institute of Medical Education and Research in Chandigarh, India. He's a leading expert on vitiligo around the world, extremely well published, a very nice person to work with, and it's a pleasure to introduce him to talk about recent advances in the surgical management of vitiligo. Davinder. Davinder, I think you're muted if you want to start.
Thank you, Dr. Seemal, for a very kind introduction. Let me share the screen. So the topic I will be discussing today is on the surgical part on the management of vitiligo. We have like few talks covering this aspect as well. Very nice talks yesterday also, and today one talk by Dr. Saad as well. So I will be just focusing on the current scenario, like our journey from tissue grafts to the cellular graft, which has changed the horizon of surgical management of vitiligo. So this is like we are listening since yesterday. When we started, we have hardly anything to offer like 25 years back. So we moved from steroids to now very specific JAK inhibitors. So many talks on JAK inhibitors. We never knew like in few years we will be having such a focused therapy for the vitiligo and interest for the vitiligo. This is a matter of personal satisfaction. So now we are moving toward our aim of total repigmentation and complete stability. Then comes the role of surgery when after stabilize a given patch of vitiligo. So when there is no further improvement with medical management, we have to think about giving the melanocytes from the normal skin. So initially that stability is a big issue, like for taking patient for surgery. So I will not be going much into detail of this concept of stability, because especially for non-segmental vitiligo, it's very difficult to define a true stable vitiligo as of now, as we had yesterday talks regarding how to induce stability by targeting like interleukin 15 or its receptor by Dr. John Harris. So, but the future is like even we are moving from global stability to lesional stability for taking the patches for surgery. And moreover, recently we are working on this newer concept. Can we induce the lesional stability by giving something to the patch by surgical management? That could be a sort of a big breakthrough in the surgical management if we can stabilize the local patch with the surgical management of vitiligo. So this is a paper we published a few years back where we looked at between this cellular grafting versus tissue grafting, and we found like non-cultured epidermal cell suspension is significantly better than suction blister epidermal grafting or other tissue grafting. So many advantages. So I will be just focusing on this non-cultured epidermal cell suspension. And over the years, when we started about 20 years back doing this non-cultured epidermal cell suspension, so aim of our team was to just simplify this procedure so that this can be done at many places across the world. Otherwise, initially, when this procedure was started, so it was supposed to be a very lab-dependent procedure requiring some high degree of training and lab support. So, but we have modified it to such an extent that any dermatologist having a small electric setup where there are minor OT setup can do this procedure. This is very safe and effective modality. So we can treat larger area, color match is excellent. We can treat any area. There's hardly any difficult to treat areas. So this aim of this treatment is just to replace the melanocytes that are missing. So it is basically broadly a 3-step procedure where we first step is taking a graft, then we trypsinize it for making this suspension which is rich in melanocytes, and then applying the suspension. There are many modifications, and it can be, aim remains the same. So this was started by Gauthier as this a 2-day procedure where he used to take a graft and then to raise cryoblisters, and then suspension was injected into the cryoblisters like this, and the results were excellent. So similarly, this is our conventional method where we take a graft and then trypsinize it, prepare a suspension, then after dermabrasion we apply the suspension and simple dressing is done, and then we wait for 5 to 7 days, and then dressing is removed. So this is a simple our method of taking a graft, whereby with just a normal shaving blade held in an artery forceps with a seesaw movement, we take a thin graft. As you can see through this, you can it's so transparent you can read through this, the brand name over this blade. So this is how we take graft, and this is again a simple which can be learned very easily. So I just run through few of the photograph before and after to show any area can be treated, large area can be treated. So the results are, I think, quite good in most of the cases. So even there is a significant improvement of leukotrichia, which is usually not seen with other surgical methods. Like here, quite a significant improvement of leukotrichia. So there is also now, actually there is not a clear mechanism how this retrograde migration is occurring and how this after surgical introduction of melanocyte to the patch, how this there is an improvement of the hair. So that we are working on this to understand the mechanism behind this in the repigmentation of leukotrichic hair following this non-cultured epidermal cell transplantation. So looking at this, like we have hair follicle as a good source, because hair follicle is a rich in melanocyte stem cells. So this is a good source for stem cells. So this is one of the method where one can prepare a hair follicular cell suspension, and that the procedure remains more or less like the same, but taking the melanocytes from the hair is a little different, but it is as easy as from taking its skin. So in a comparative study, we compare the two. We found it to be equally effective, because we know the melanocytes suspension when we prepare from hair follicle, it is rich in stem cells. So we can expect that better result, but the number of cells are less, because we need as such epidermal cell suspension contain more number of cells. Probably that's why they are equally effective. So this is the case following treatment with hair follicle cell suspension. So the results are equally good. So this is what I was mentioning, the fascinating pathway or the journey of the surgical management. We started from the tissue grafting, then moved to the cellular grafting. So then we have this non-cultured epidermal cell suspension, hair follicle cell suspension. So we tried combining the two, taking the advantage of stem cell hair from the hair follicle, plus lots of good keratinocytes as well as healthy melanocyte with this. So the results are better with the combination. So then we did a modification and simplification and simplified 4-compartment method with hardly any lab support is required for this procedure. And now we are working on this, as I mentioned in my first slide, that can we induce the stability of the patch by introducing this melanocyte stem cells if we prepare dermal cell suspension. So this is, I was mentioning about our 4-compartment method. So because of paucity of time, I will not go much into detail, but I can promise any dermatologist interested in vitiligo surgery, after looking at these videos, we can provide them. I have my email at the end of my slide. So I would be happy to share these videos. And then this is a very simple procedure. Like here we need just this 4 partition plate. And in the first well, we take that I showed in the epidermal graft. So then it is in well number 2, you can have trypsin. So we can put it in, in the well number 1, it is put in this trypsin. So after 30 minutes or so, it can be washed with the PVS, which is there in well number 2 and 3, as I can show you here. And then it is moved to this well number 4. This is for washing well number 2 and 3. So here this separation is performed. Like you see, after trypsinization, epidermis and dermis peeled off, and then we take only that much solution which is required to be applied over the dermabraided area. So there is no need for even centrifugation. So as you can see here, this is a cell suspension which has become turbid, so means rich in cells. So this can be applied over dermabraided area, and the result is as good as conventional method of trypsinization. So this is any dermatologist who has interest in doing this surgery, so with a basic precaution, they can start doing this procedure. So this is one of my favorite slides to show that melanocytes are the not only cell which is defective in vitiligo. All the cells, maybe like keratinocytes and fibroblasts, they are also involved in vitiligo. So they are not able to secrete good growth factors for melanocyte like ACTH, alpha MSH, ET1, nerve growth factor, BFGF. So that was an idea to supplement good number of even keratinocytes, or finally also the dermal cells in a suspension. So in this paper, which we published in this JAMA Dermatology, so we combine the two, follicular and epidermal cell suspension, with the same principle that good number of healthy keratinocytes and melanocytes from the epidermal cell suspension, and melanocyte stem cell from the hair follicle cell suspension, and we combine them together. So even over the acral part, we get good results of combining this epidermal cell and hair follicle cell suspension. So we did this in vitro study also to show that there is a more of BFGF when we are combining the suspension. This is probably reason we get better repigmentation when we combining the epidermal cell suspension with hair follicle cell suspension. So as can be seen here, we found the combination works better than epidermal cell suspension alone. So this is the current concept of introducing this dermal cell suspension in a hope that it can induce the stability in the patch. So in this study, study was based on this paper which was published few years back in the PLOS, where they have shown that this dermal melanocyte stem cell, they can sort of act as immunostabilizer. They can sort of suppress the skin homing of CD8 T cells. So that's why we planned this study. And in this study, we took vitiligo, which was stable just for like 3 months only, and compare it with the normal. We take like 1 month, 1 year stability. And we found that when we introduce this dermal cell suspension along with epidermal cell suspension, so even in a 3-month stable patch, behave like as good as a stability of 1 year. So but we need a long-term study to look at how long this stability will going to last. So after this initial study, now we are having a long-term study where we are looking at the difference between the two, a 3-month stable patches versus our conventional more than 1 year stable patches. So the result of this, we got good repigmentation following this combination. And getting this, preparing this dermal cell suspension is a very simple procedure. When we take a graft for epidermal cell suspension, we take just one 4 millimeter punch biopsy, maybe from the same area. And then there is overnight treatment with collagenase. And then next day we prepare the dermal suspension. So then it is very easy to prepare. And I can also share video for preparing this dermal cell suspension as well. And the results are again very good. But here we need to look at long-term stability. Like if we can induce a stability in a very short, like a 3-month stable patch of vitiligo. So that will be clear after the result of our long-term study. Thank you for your attention.
Thank you very much, Davinder. That was an excellent presentation. And we will take a couple of questions now that have come in over the chat. There's been a few that's come into the whole chat. I've received a couple of private questions for you. The first question is, can you describe specifically any special bandages or dressings for the after grafting when you discharge the patient home?
Yeah, after the procedure, we here prefer the collagen dressing because the collagen dressing act like sort of a film over the dermabrasion area. It can hold the suspension in place. So that is the advantage of using collagen over the when we put that suspension over the dermabrasion area. Then we put this collagen sheet, so which forms sort of like a graft, and it can hold the suspension in place. So that is the only reason we prefer like collagen. And then we after this we do the standard dressing. So this is the advantage of using collagen.
Perfect. Excellent. The other question was, when you discuss follicular stem cell transplant versus dermal stem cell transplant, can you clarify how you're harvesting these differently?
Yeah. Hair follicle cell suspension, we are plucking the hair. So this is anagen hair, like we take the two method, like one is just traditional method, what we do in hair transplant, follicular unit extraction with like 1 millimeter punch or 0.9 millimeter punch. And then we take about 25 to 30 FUEs and then trypsinize it. And other method is plucking the anagen hair follicle, like about 50 to 100 hairs are plucked, anagen hairs are plucked, and then they are trypsinized. So we compared in one of the study, and we found that FUE is a better, but it's a more invasive procedure. Like, but the plucking of hair is a less invasive procedure. So one can weigh the advantages between the two. So then the trypsinization, I can share the video maybe uh, if someone is interested to how to do trypsinization from the hair follicle. And for dermal cell suspension, we take just 4 millimeter punch biopsy and then overnight treatment with collagenase. And next day is just like a mashed and prepared suspension is prepared after separation of epidermis. So this is again very simple procedure.
Very good. The other question that's come in is related to transverse needling as a new emerging technique in the surgical management of vitiligo. Can you comment on transverse needling?
Yeah, this is like one of the method, but here again, like I mean, like needling when combined with this surgery, I mean, this suspension method or needling alone. I mean, the question was.
The question is needling as either an adjunctive treatment or related to surgical management, your experience in that.
We did one study and we found this needling without application of suspension not very effective. So one method of introduction of suspension is by like derma roller. So, and then we can put the suspension after derma roller. So that can, I mean, work, but needling alone, maybe it has some role. To my mind, it's not very effective method of treatment.
Very good. And very quickly, Davinder, we'll take one more question. Any experience using dermal cell transplant alone, either in animal or human studies?
Yeah, so there are no such study, and I don't think anyone has taken a dermal cell alone, because in that case, we expect the repigmentation to be very slow because the number of, I mean, how it will behave how will melanocyte stem cells from the dermal cell, we know they are there, like melanocyte stem cells are there in dermal, can be converted. Even in lab, we have converted them into viable epidermal melanocytes. But uh, uh, we don't have experience of using dermal cell suspension alone in the management.
Very good. Davinder, there's lots more questions coming in, but I think we can go ahead and take one or two more. One, because there's several questions for you regarding stability. So in any of your patients where you treat vitiligo with surgical management, what is your cutoff for how many months stable the patient has to be before doing the therapy?
Yeah, conventionally we take 1 year stability as a criteria for taking the patient for surgery. And as I mentioned, for dermal cell, that was an experiment.